Hello, and welcome to the Houston Methodist Post-Grand Rounds talk. I'm delighted to have Dr. Niv Ad here with us today from Fairfax and Inova Heart Center. And Dr. Ad just gave an incredible, very enlightening Grand Rounds talk, and we were very fortunate to have you here as our visitor. And thank you so much for coming and letting us know what you've been doing in the field of atrial fibrillation surgery. As we've headed towards the gold standard of trying to find how we should be doing this and how we should go about doing surgery for atrial fibrillation, we look back at Dr. Jim Cox, who developed the gold standard of what we are striving for right now with the cut and sew maze procedure. So at what level do we draw the line? Where is it appropriate to draw a line between minimally invasive and efficacious operations? Where do you think we should be right now, and where should we be heading?
So thank you, Ross, for the introduction, and it's always a great pleasure to be here in Houston and in Methodist with all the history, especially surrounding cardiac surgery and vascular surgery. So it was really a great pleasure of me to give the talk today, and again, thank you for inviting me. I think that your question is really the key question of how we move about, with and what to offer to patients that are having symptomatic atrial fibrillation and to some extent have pending strokes or the high risk of having a stroke. So I think we are fortunate that today to have a true minimally invasive approach to mimic the Cox-Maze procedure as was done by Dr. Cox in the 80s and the 90s with the cut and sew maze procedure, utilizing reliable energy sources, mainly cryo and bipolar radiofrequency ablation. I think in this day and age we are fortunate to be able to offer a reliable minimally invasive approach to a very small incision, utilizing all the lesion sets that were done by Jimmy Cox in the past with cut and sew maze procedure in the 80s and 90s, and by so doing minimize the trauma to the patient and promote healing. We're doing it using reliable energy sources such as cryo and bipolar radiofrequency ablation that with those two devices, either cryo alone or combination of bipolar and cryo, we can basically run the entire lesion set of the Maze 3 or Maze 4 procedure and expect the same success rate. Having said that, there are some patients that are not good candidates for minimally invasive approach and will still require median sternotomy. And I can tell you from our own experience, some of the patients that have had multiple ablation and are highly symptomatic, they come to me and say, no, we don't want anything fancy, we want a mid sternotomy, we want to get over with it, and we don't care to have a larger incision, we just want to get rid of atrial fibrillation, because some patients can be very sick with atrial fibrillation. I mean, their function level is very minimal, and they are almost bedridden and relatively young sometimes.
Now, I've seen the same thing, that patients, once you start talking about the outcomes, and when you're offering them, especially if you're offering a 98% freedom from stroke at 10 years, as your data showed, I think the patients who are coming to surgery, they're coming to have an operation performed, and they want to have the best efficacious operation that's possible. And your data has shown that you can do this operation through a small right mini thoracotomy on a short cardiopulmonary bypass run with very little morbidity, 0 to almost no mortality in all the patients. And so I think this is a really a great opportunity to give patients a chance to have one procedure that will give them a very high likelihood of being free of AFib, which is very destructive to them, and especially to have a freedom from stroke. In your experience, do you feel like the freedom from atrial fibrillation or ligating the atrial appendage or a combination is really important for that freedom from stroke that you've encountered?
Yeah, I think that's a key question. I don't know the exact answer. It's probably both. So we have high success rate, and the definition of failure is somewhat strange to me, because the failure is anything over 30 seconds. So you can have someone being monitored for 3 weeks, and all they have is and we had examples like 47 seconds of some run of supraventricular arrhythmia, and they're still a failure. So clinically, the success is maybe higher. As I mentioned today, half of our documented failure had events only between 30 seconds to 5 minutes on long-term monitoring, which is a very, very low burden. Having said that, I think there are other issues, and especially good control of the appendage. So the combination and the fact that we can wean off patients from anticoagulation in high rate eliminate almost the stroke, either from thromboembolic event or bleeding. But I can just give you one example how you can work with the industries around technology to improve what you do. So as you know, we used to close the atrium from the inside with a minimally invasive approach, and we found that at least in 4 to 5% of the patients, long term, there is some degree of recanalization, although at the time of surgery it was perfectly closed. And this is why we started, together with the company that developed the clip, to work on an approach through the right chest, under the aorta, through the transverse sinus, to clip the appendage from the epicardium and have a long sustainable closure of the atrium. And we just recently published our initial experience. So I think the beauty of cardiac surgery and cardiac surgeons is that we always want to get something better and better and better. So we minimize the approach, we improve the tools, we work with the industry to improve the ablation devices in an hope that the future will enable us to do the procedure without the heart-lung machine. Not that I think that the heart-lung machine is dangerous, it just add another level of complexity to the management of the patient. So I think that's why we need to take part in this process. We need to improve our communication with the electrophysiologist and create camaraderie and heart team approach, which is a patient-centered approach.
As we try to move towards a less invasive approach, and I think of less invasive as all parts of the operation, not just the incision, but as we try to move towards that, I think the hardest thing that we have to do with a less invasive approach is take care of the mitral isthmus line. Have you found anything that other than cryo from an endocardial approach that you feel safe to safely go across the mitral isthmus line and treat the coronary sinus and the all the way across to the mitral annulus? Have you found an epicardial approach that you think is safe?
No, and I think that's one of the areas that we are really lacking the appropriate technology for true minimally invasive, epicardial approach, because of the way it's also folding, in that area, and the importance of the coronary sinus. So, going back to invasiveness, and I'll get back to it in a second because I think that's an important lesion. The most invasive thing we can do is basically doing a surgery and not treating the patient, meaning have a failure. This is the most invasive thing we can do because the patients are miserable going through surgery and go through failure. One of the most devastating failures for any ablation for atrial fibrillation is the development of what we call atypical flutter, or now they call it, mitral valve isthmus flutter or left atrial flutter, which is a flutter around the mitral valve and the isthmus between, basically the pulmonary veins and the mitral valve at some level. And that lesion is so important that in the original MACE procedure, Dr. Cox used to leave a clip where he did the lesion, so in case there is a recurrence there, the electrophysiologist will know exactly where the line was, so they can go there and map it and complete it. So this is why I think it is very important to use, if you do this lesion, which you should, otherwise you have probably about 15% failure rate, you should do it appropriately. Because if you don't do it appropriately, you actually may make things worse and create a failure that's devastating, much more symptomatic, and it's very invasive to the patients because there is not good treatment with catheter based to that. So you are right, and I think this is a very important question. This lesion is the one we need to focus on and how to perform it, in a more minimally invasive way.
I think it's very hard for the electrophysiologist to reach that lesion safely, and it's very hard for surgeons to reach it from the outside. And I've seen papers that talk about going towards the coronary sinus but not actually across it, and I think that's creates a devastating corridor that really can make the symptoms much worse. It's much harder to treat. Now, as you reflect on your career to date, which has been very productive, very illustrious, what are your thoughts on your cardiac mentor, namely when you came to the U.S. and you've gotten an incredible experience? What are your thoughts on your mentors?
Well, mentoring is a key, and this is one of the things that I miss the most, being able to be a mentor to someone else, because I'm in a private practice with very few fellows. But I always say, the fact that I was able to be so productive and so involved in the field is only because of my mentor. It's the thing he taught me when I was his fellow, mainly to be very meticulous in my surgical technique, never compromise, and it doesn't matter which type of surgery, if it's coronary or mitral or aortic, any surgery, never compromise, and always ask questions. And one of the fascinating phenomena about working with Dr. Cox, day in and day out, making rounds with him, that he always asks questions. And he was when you brought up a good point or an interesting point or something that maybe should be investigated, he never turned back and say, "Oh, you are just a fellow, you know nothing." Let's take a look at it. It's interesting, So this is what makes him so special, and I think he helped me a lot in my evolution as a surgeon and as a researcher to some extent. To be able to ask questions all the time and not accept, something that I don't fully understand. So I thank him for them. And I think the best thing I've done is basically stick to the principles, and until I'm convinced that there is something better, I'm not going to change. And I had multiple opportunities to change, and at the end of the day, we never change, and we are stuck to what he was doing with some tweaks to make it more minimally invasive. But I think this principle is the only one that is reliable right now, unfortunately, because we need to decrease our the invasiveness of the procedure. But hybrid approach and team approach and new technologies, are here to come, and this will definitely. One of his own visions, because he's still very involved in developing next generation tools.
As we push towards the gold standard, as we push toward trying to get a uniform following for a biatrial maze lesion set, what do you think what do you think is the best energy source as we go forward? And what do you think is the best way to follow these patients? Because the follow-up has been so heterogeneous in the literature, it's been really hard to determine. We had everybody had 80% success rates with microwave, with ultrasound, with laser. Everybody had 80% at 6 months with random follow-up. We have guidelines that point out how we should be following. How do you think we should be following these patients?
Yeah, I think so. You have two very important questions. One about the energy source. So, there's a lot of involvement of industry and somewhat of our technology is better than the other and so on and so forth. So I think the definition of energy, of the perfect energy source, it doesn't matter if it's cryo or not. Although I'm like you using cryo as my first goal. is a reliable tool that's going to give us transmural lesions, day in, day out, 100% of the time. And there are some thoughts how to get to a tool like this in the very near future. The more important question right now is how to follow patients. And I think surgery and non-surgery, the medical literature and also the EP literature, there was a lot of gray zone of how to define success and failures and all those other aspects of the outcome. And what's important with the HRS expert consensus guidelines and some other guidelines came about after that they try to now make sense, standardize the approach. So I think first and foremost you need to work on some type of a registry and follow up regularly for the first year, and then annually, thereafter for as long as you can. Now, that being said, resources and support for that is not a given anymore, and this is why you may want to work with payers to support it, because it's also important to payers. So, how to follow the patient, whether a spot EKG or Holter or longer-term monitoring or Reveal XT or Reveal Link or all those other devices, that's a different question, and it's an ongoing debate because some of those devices have very high false positive, very high false negative, and being able to review all the data is really a huge burden, and so on and so forth. So I don't think we are pretty settled about that. And even if you put a Reveal, which is a continuous monitoring, it goes only for 3 years. So what are you going afterwards? So I think this is still a moving target. But I think the minimum you should do is Holter monitoring in those time points, although this is not being reimbursed all the time. So at least an EKG, follow questionnaire, medical records, medication, and then you can complete the clinical and the through monitoring type and create a sense. So that's what we do. We have Holter monitors at each time point, and we have long-term monitor at 6 months and 2 years offered to all the patients. The compliance is not that high for them. Right. And we have some with Reveal and some with others, but we try to standardize it, and we do follow the patient at each time point. Right now we have over 1,000 patients in the registry following patients continuously.
And another challenge is trying to figure out how the nomenclature of how to classify these patients preoperatively. The risk factors you mentioned, the duration of AFib, the size of the left atrial appendage, the size of the left atrium, and the other risk factors for failure are very high, and the literature is very sparse in actually reporting the numbers of these classifications.
Yeah, I think actually it's an interesting point. We just submitted a paper which is showing how we failed in trying to perform a meta-analysis of the literature to answer this very question. Basically, preoperative predictors for failure, intraoperative lesion set, and success rate over time. So the literature is so non-standardized in that respect that we basically report on a failure to perform a meta-analysis because of lack of different levels of missing data in right. So many aspects of papers, and it is a call for action actually, because we do need to be able to report on the same things, and this applies also for the EP literature. So I think moving forward, it should be a collaborative effort between the editors of the journals and the reviewers in the journals, not to accept papers that are not reporting these variables, not because the paper is lousy or the data is not important. It's because you cannot do anything with the data.
Right.
We have to start to move this needle and have more so-called evidence-based.
Well, we have several challenges ahead, and I really appreciate you carrying the flag and getting us on the right track with your data and your analysis and the way you go about this clinical problem from a scientific approach. And again, thank you very much for coming and joining us here. It's been
Thank
a pleasure.
you. It's a pleasure. Thank you very much.